Welcome back to the Bedside Murmurs podcast, where we chat with doctors about their careers, pathways in medicine, clinical tips, and much more. If you have any tips or questions, or have any ideas for guests you would like to see on this show, you can please send us an email at podcast@medsoc.org.au or direct message us on Instagram at Bedside Murmurs. I'm Sean.
And I'm Emily, and we will be your hosts. Today, we have the pleasure of interviewing Dr. Linny Phuong, who is a paediatric infectious diseases physician, a PhD researcher, and a teaching fellow. Dr. Linny is passionate about health equity and accurate health communication. Dr. Linny is the founder of the Waterwell Project, an award-winning health promotion charity which has provided over 2,000 health education sessions to communities from migrant, refugee, and asylum seeker backgrounds. Outside of this busy schedule, Dr. Linny contributes as an active committee member of the Australian and New Zealand Paediatric Infectious Diseases Group, the World Society of Paediatric Infectious Diseases, and the Consultative Council on Obstetric and Paediatric Mortality and Morbidity Infection Working Group. She's also a regular guest presenter on ABC News Breakfast. Welcome, Dr. Linny, to Bedside Murmurs. It's a pleasure to have you here with us today.
Thank you so much for having me.
Tell us about your journey through medical school.
I was someone who always wanted to do medicine. So as far as I can remember as a child, I wanted to do medicine. And suffice to say, I went through high school and I was quite young. I finished when I was 16. I had an interview for medicine and I completely flaked. I think I was just so almost desperate in a sense to get in that I couldn't string two sentences together in the interview. And I think in hindsight, I was devastated at the time, but in hindsight, it was probably a good thing. I went and did postgraduate medicine. I did pharmacy, and then I went into postgraduate medicine. And I think that sort of pharmacy foundation has probably set the tone for my future career, although I didn't know it at the time.
Mm. What were some of those skills that you learned in pharmacy that translated well into medicine?
Yeah, I think being in primary healthcare is a very different skill set and just a different interaction in terms of patients compared to being in a tertiary hospital. So learning those skills of how to interact day to day, to give health promotion advice one-on-one and almost casually in a sense, but also to be sort of part of a community and get to understand some of the barriers that exist within small communities. So I worked at one stage at 5 different community pharmacies.
Oh, wow.
Yeah, just for variety. Yeah, it was a lot.
As you do.
As you do. I would drive out of my driveway and think, what day of the week is it? Which pharmacy am I going to today?
A different one.
A different one every day. And I think, it was different demographics, different doctors and prescribing practices within each of those settings. So I think, I was learning a lot, and also I guess having that pharmacy background means that I had a one-up in terms of pharmacology when it came to med school.
Absolutely.
If only.
If only.
We should have this is such a play. We should have gone through pharmacy first. Pharmacology might not have been so bad for us.
Yeah.
Going through pharmacy, I think that's a very interesting pathway. A lot of people kind of see pharmacy either as an end career path, but
yes,
I think a lot of people do go through pharmacy with the intention of maybe going into medicine later on. I think also people who went directly into medicine don't really have an understanding of how pharmacy works because they just go like, prescribe drug.
Yeah,
and
some
pharmacists will do something.
Yeah.
What do you think is the thing that, as a doctor, most doctors do not understand about the pharmacy profession?
Yeah, I think it's that intimate drug knowledge, and I think I should actually preface this by saying that when I went into pharmacy, I thought that was my end game. I thought that this is it. This is what I'm going to do. I missed out on medicine. Probably wasn't for me. But yeah, going through pharmacy, I loved the training. We learned about formulation of drugs, molecular chemistry, like organic chemistry, and God, I've not been able to draw a molecule since. But we learnt the fundamentals, and so I think as a doctor, the skills that we learn, are complementary, and I feel like as doctors, it'd be great if we had a better understanding of what our allied health colleagues do, because they add so much value and they have just a different skill set and a different knowledge base. So. Gosh, it'd be so good to actually work together in an interdisciplinary way. And yeah, it'd be great to be able to learn from each other better. And I think that's something that needs to be better integrated into the curriculum, to be honest.
Yeah, 100%. I think for us, we don't, as like going through medical school, obviously I'm not 100% sure 5th and 6th year, it might be completely different for us. But as far as I hear, it's not heavily put into the syllabus, like, you know, how are drugs formulated, how does it work? You going through medical school, you probably thought that like a lot of what you learn in pharmacy is going to carry over to medicine, but I think you learn so much more in pharmacy that you just do not.
It's so much more in depth, exactly, and it's almost to a point assumed knowledge in some ways. But you know, having said that, I was very jealous of my physio colleagues with their deep anatomy knowledge.
Oh, that's
so you know, horses for courses.
And when you were a medical student, what areas of medicine did you enjoy?
Yeah, I really enjoyed the clinical aspects. So preclinical, the theory, I don't know, not so much. But I think the things that I enjoyed the most was getting into clinical school, being able to sit by a patient's bedside, ask them stories, hear their stories, and you know, I always think it's such a privilege for us to be able to do that and hear from people at, you know, their most vulnerable times. I think that that's something that I've carried through, and I feel like the reason why I ended up in paediatrics is because I had such a fantastic rotation at the time. I was in denial for a period of time. I went through internship. I absolutely loved where I was. I was surrounded by these amazing young gun like consultants, and I thought adult medicine is for me, so much so that I did a second year of adult residency, thinking that that's what I was going to do. I was going to become a physician. And I think what ended up happening was I kind of went back to thinking, you know, pediatrics was fun. It was a different type of medicine. It was a different way of interacting. And yeah, I ultimately went back to it.
Yeah, it's kind of also interesting. We don't really do too much pediatrics until you go in and actually do a pediatric rotation. I also find it kind of hilarious that all of medicine kind of funnels yourself.
We're shunted through adult medicine, aren't we? Yeah, that's true. And I think during medical school, I made opportunities to try and get a better understanding of pediatrics. Like I did a pediatric elective. I volunteered for the Red Cross and sat in pediatric emergency departments and served cups of tea and coffee. I did all these little things like little research projects and things. I did Teddy Bear Hospital, as most of us do. And so I think it was really that discovery of, you know, like how much do I enjoy being around kids and can I do this for my, you know, long-term career?
And what do you think were the big differences between pediatric medicine and adult medicine?
I think there are lots of differences. I know our adult physician colleagues tend to think of pediatrics as veterinary medicine in some ways because, you know, obviously the patients can't tell you what they're thinking.
Oh, that's true.
And you kind of have to make assumptions. I really like pediatrics because, you know, when you see a kid who's unwell, yes, it's awful. But most of the time they bounce back, and when they do, they're literally bouncing off their bed and running through the wards, and it's just, I think it's the most joyful and rewarding thing. I also like that exchange of information with the parents. You know, I'm a bit more of an optimist in that I believe that most parents do want the best for their child. And so when you are speaking to someone who is advocating for the care of someone else, I think that interaction is really nice, and it's that whole kind of health knowledge, health literacy piece that I think I've become quite passionate about.
And how did you find yourself in infectious diseases in pediatrics?
So I was quite fortunate through my pediatric training. I was exposed to lots of subspecialty units, so hematology, oncology, gastroenterology, neurology, nephrology, and then ID. And I kind of embarrassing. So my boyfriend, now husband, at the time kept finding me in corners like reading things and, you know, like almost like secretly hiding. It's like, what are you doing? And I would be reading up about, you know, a patient that I saw and reading, you know, the in-depth journal article. And so I think at the time I didn't realize how much I enjoyed infectious diseases. But yeah, he kept catching me out and realizing that, oh God, like maybe you do like this more than you think you do. I was reluctant in the beginning because I was told that there'd be no jobs in Paediatric ID. and that it's, it's competitive and it's such a niche specialty. At the time they were, in Victoria, there was only one place for a trainee at the Royal Children's and one at Monash.
Oh, wow.
So it's super, super niche, super exclusive. And I was fortunate enough to get both of those positions. But I think ID is fantastic because it's problem solving. It is working with multidisciplinary teams. You, in the teams that I've worked with, you don't own your patients, so you are consulting on an oncology patient or a gastro patient who's been started on biologics, or a rheumatology patient or a trauma patient who unfortunately has been exposed to stuff and is at risk of infection. So I find it really fascinating, and I like working with other people. So yeah.
Yeah. How does that like meld into also pediatrics as well? You know so much about infectious disease.
Yes.
You're now consulting
Yeah.
for infectious diseases, childhood
Yes.
infectious diseases. I think we've all had childhood infectious diseases.
Yeah.
And then you go to a GP, and a lot of times you're kind of just not too sure what it could be. And it's not because they don't know,
Yes.
but it's literally just because it could be anything.
Yeah.
And it really is a subspecialty.
Yeah. I think GPs do an impossible job, and I do not think that I could do it. I think to have multiple patients coming through your clinic room and have to pick very sick from standard virus would be so hard. So I think specialists in a hospital system are quite privileged because by the time they get to us, somebody's already kind of said that they are sick enough that they need to be in your care. So yeah, I think it's quite different. But yeah, with Paediatric ID, I think we see a very exclusive, like a very small subset of patients. But at the same time, we are looking at the whole system, which is fascinating.
What is the kind of filter that gets to you, if that makes sense? Like, I think we learned a lot of pediatric diseases.
Yeah.
And
Like
we
what
know,
conditions?
what conditions actually end up at your door.
Yeah. Okay. So for example, we would see the immunocompromised patients with, viral infections, and, a lot of viral infections in a normal patient, you would be okay. So a rhinovirus infection is generally considered the common cold, but in a oncology patient might get them into ICU.
Yeah.
So we will see that sort of patient. We'll see trauma patients, like burns patients who have lost, layers of skin and therefore are exposed to, again, like environmental bacteria, which often is not a problem for most people. We'll see some of the odd, like bacteremias, so bloodstream infections with, Staph aureus. We saw a lot of group A strep infections a couple of years ago. I think it's when things are a little bit harder in terms of that niche knowledge. I think the other thing that's really interesting about Paediatric ID is because some of the drugs have not been tested in kids, we don't have all of the evidence there. And so some of our work is in being able to distill the literature as we're seeing cases and try and draw conclusions from what we've seen in adult ID. So I find that really fascinating as well. Like, I'm not a flowchart person, so clearly I am not an endocrinologist, I'm not an oncologist. Some people really like that protocolized process, and that's not how my brain works.
Your dosages are just actually titrating it.
Oh yes, yeah. Milligrams per kilo, exactly, and then figuring out whether or not an adult drug is going to work in a child.
And it like the physiology is completely different.
It's very different, exactly. And then when you go from neonates to children, it's different again.
Yeah, you're actually dealing with, like, adult medicine deals with adult patients, but like pediatrics, you deal with like at least 3 to 4 stages of life.
Yes, yeah, super interesting. Very cool. Please come to Paediatrics.
What do you think some things that medical students might not know about working in infectious diseases? Because we often don't see that in medical school.
Yeah. I think the main thing is really that stuff around multidisciplinary care. I feel like what you don't see is that when we have a patient in front of us, often we are working with the surgeons and the oncologists and the immunologists, for example, to be able to come up with a treatment plan for a patient. And again, like I said, I love that. I love that we're working with different specialties because, everyone brings their niche kind of knowledge. And it just makes, every case so unique and so interesting.
Yeah, like a dream team.
It is. The dream team doesn't always work, but But we try and make it work. But yeah, I think it's just being able to work with different specialties. So it's not just about, getting rid of the bug or prescribing an antibiotic. I think that's probably the misconception. It's about how do we control or find the source and then control it.
Yeah, I think also it's valuable to think that most of medicine is still kind of uncharted. We don't really know that much in medicine.
Yeah.
And also, like, we do know a lot, and it's kind of also spread between a lot of specialties because it'll be so difficult to kind of compile all of that into one person.
Well, I think that's why AI is coming, isn't it?
Yeah.
Well, it's here.
Yeah, it is here already.
And we've got to try and move with the times.
100%. But for now, it's still like multidisciplinarity is still the backbone of the healthcare system.
Yes.
Because we need subject-specific knowledge in everyone. And also, I think AI can do a lot in terms of
integrating it all.
The knowledge.
Exactly.
But you still need the people at the front lines actually like carving the path. And as you said, like you're doing like the titration of medicine for children that literature doesn't exist for.
Yeah.
And AI can't do basically experiments themselves. They have to do that.
Yeah.
Using,
I know. We will see.
But you still have to provide the data set for them.
Yeah, that's right. Exactly.
And so you are still necessary, and doctors are still necessary in this grand scheme of things, because in that field, you still have lots of things that there's just not enough data for us to rely upon big data sets, AI, to actually give the kind of clinical knowledge.
Still got a job.
We'll do it. At the moment, we still have a job. That's right.
Yeah.
But watch this space.
Watch this space.
Another area of medicine that you're quite passionate about is refugee health.
Yeah.
You're the founder of the Waterwell Project. So what's the project and why did you start it?
Yes. How do I distill this in a couple of sentences? So the Waterwell Project has been going for 14 years. I started it as an intern doctor, so a naive intern doctor who thought I had more time perhaps than I actually did.
Oh, don't we all?
I know, that's right, exactly. And in terms of, I guess, what we do, we provide like culturally appropriate, interactive, practical health education to communities from migrant, refugee and asylum seeker background. So what that means on the ground is that we are sending healthcare professionals out into the community to have dialogue with communities about health topics. So, for example, a women's group who might meet every Wednesday at a community centre who are of reproductive age might ask us for a session on antenatal health. And it, as I said, like it's very much about having a Q&A dialogue with them, because a lot of these communities do come with knowledge and they come with stories and different experiences. And so our job is really to fill in that, the gaps of knowledge and figure out whether or not what they understand is, I guess, and how they navigate the healthcare system is correct, and try and dispel some of the myths and misconceptions that often exist.
Yeah, and it's so important because I think migrant families, they come into Australia, they don't know, like maybe they have troubles with the language, and if that is the case, or they might have cultural differences as well, that's a massive barrier to healthcare, and the limit to what the healthcare system is able to provide is whether or not the patient actually comes to the healthcare system. If they don't know it exists, if they don't know how to look for it, if they don't understand what the doctors are trying to tell them about the health, or they're not able to actually embed it into their being because it has some kind of fissure with their cultural practices. It's so important to provide that safe level of healthcare, that culturally aware level of healthcare. And
can you come and sell the Waterwell Project? Mike, you've just pretty much explained exactly what we do, because you're right. Like if they don't understand the healthcare system, and this is my thing around how important health literacy is, because health literacy is not just about giving someone a translated pamphlet. It is about knowing how to get from A to B in the healthcare system. I have this symptom, so I've got chest pain, therefore, one, I know it's bad, it might mean something, and two, do I go to a GP or do I go to a hospital? And then when I'm at one of those places, what do I need to tell them for them to be able to treat me accordingly? and how do I get there, and all the other steps in between, and the steps following, like getting that yellow script, that piece of paper, like what does that mean, and what do I do with that? So you're exactly right. Like if you don't know how to navigate the healthcare system, then you are at a disadvantage, unfortunately.
And what drove you to start the project, and what continues to drive your efforts for the project?
Yeah, no, that's a good question. I mean, firstly, it wasn't an on purpose. Like I did not decide that I was going to start an organisation, and that for me that was never the story. I actually it was a chance kind of encounter. A friend and I had delivered a healthy eating talk, and it wasn't even a talk. We were at a Sudanese homework club, and it was a weekend. We went out and we taught these kids, these primary school kids, about they had the junk mail catalogues that you get with like fruit and veggies and Woolies or Coles. They were literally cutting out pieces of food, like cutting out chickens and cutting out packets of cereal and things, and we were teaching them based on those catalogues what was healthy and what was not healthy. So that was literally our little session. And the chance encounter is that the next day I went to a birthday party and I met someone who was working at the Brotherhood of St. Lawrence at the time. So one of the kind of big migrant and refugee support organisations within Australia. And so she casually asked me, what did you do yesterday? And I told her about this session, and she said, oh, that's really interesting because they had just done a needs analysis of their refugee population at the time, and this was, 14 years ago. At the top of their list was health literacy. So she said, with what you did yesterday, do you think that you could build a model and something that you would be able to scale and get some of your friends together and deliver some health education? And naive intern me said,
yeah,
sure, why not? And so, it was kind of a series of meetings from there. And, suddenly we were, an incorporated association in Victoria. We had started delivering sessions, and it was myself and some doctor friends. And then, we were building partnerships. We were meeting with refugee organisations. And then, then we're in New South Wales, and then we're in Tasmania. And we're this national organisation, and now sort of partnering to do research in refugee health. So, just kind of one thing led to another. I think it was, chance encounters, but also some amazing partnerships. And I guess people who believed in like what we did, because right now we have 400 healthcare professional volunteers,
Wow.
That's a lot.
And most are doctors who are time poor, who donate their time. So I think these are people just who believe in the mission of providing people with education to be able to, better their health outcomes.
100%.
Yeah. What is the difference between migrants, refugees, and asylum seekers, and why is that distinction important for us to know?
Yeah, I think it's really important. So, migrants are people who voluntarily move to the country. So whether it's for work or for family. Refugees are people who have been deemed refugee status by the United Nations, and they are people who are escaping from war, torture, persecution. And then asylum seekers are people who have moved here and are trying to obtain that refugee status. And the reason why it's important in the healthcare system is because if you're an asylum seeker, you're generally on a bridging visa, and healthcare, so you don't have automatic healthcare rights, you don't have employment rights, and therefore if you don't have the means to be able to make money, then how do you support yourself in housing, support your family, etc., etc. So that obviously has like flow-on effects. And so when we talk about asylum seekers, we talk about them as being the most vulnerable population. They will often have these bridging visas with these kind of temporary Medicare cards that go from month to month. So they might have a Medicare card for 3 months and then have no coverage at all, in which case they are relying on emergency services to be able to fill that gap for them. So if you inconveniently get sick in that time period, then you are relying on the hospital's compassionate kind of systems to be able to fund your healthcare, which is devastating. So I think, that's why we sort of make that distinction. So migrants probably, most kind of fortunate in some ways. Refugees have that protection, have the Medicare card, are allowed to work, go to school is the other thing, and, be employed, and then asylum seekers without.
Did not know about that. That's so
It's
useful
an
to know
important
that
distinction. Yeah, absolutely.
And also, like, I just thought, like, if you're someone that is coming into the country,
Yeah.
you might not really understand what kind of coverage you're eligible
Correct.
for.
Yeah.
And I think there's a lot of, like, I guess maybe there's a little bit of, like, healthcare fear from, like, I guess what America kind of does.
Yeah.
Where, like, there's all these horror stories of, like, people that go to hospital and rack up humongous amounts of debt.
Yeah.
And I think that is much less the case that happens in Australia, but that is not something that is actively, like, advertised.
No, that's true.
Especially if you can't get the advertising to you.
Well, that's right. And also if you don't understand the language, as you
Yeah.
said. So if you don't understand English, then how do you read the signs? How do you look up on the internet, like where you're supposed to be or where you can get help? And that's why I think this model works so well, because if we teach people within community is often their resource. So if, you know, someone gets sick in the family, they are calling their community contacts and asking them where to go. And so if we teach enough people in the community, then they can kind of act as their leaders and help people navigate through the system that way. And then if we also equip people with, you know, knowledge around preventative healthcare, because again, as you said, a lot of people who come to this country have come from countries where preventative health is not a thing. So antenatal care that we take for granted, vaccinations, cancer screening, a lot of those things don't exist or are in, you know, poorer forms for some of these individuals. And so if they don't know it exists, then why would they participate? Or why would they believe that it's actually relevant to them? So if we help them with the preventative health stuff, hopefully they don't get to the acute stages, but also we do sort of equip them in terms of recognising signs for, you know, a heart attack or a stroke, or recognising signs of diabetes, for example. So it's kind of, yeah, we try and equip them with as much as possible. And I think the other important element of that is trying to get them in there at the right time. So, you know, if someone's arriving in the country 2 weeks in, that is not the right time to be telling them about the healthcare system. It's, you know, when they have, you know, finally kind of established themselves, figured out, you know, where they can get their, you know, their food, exactly how they're going to have, you know, a roof over their heads. And that's really important, because I know that there are programs out there that perhaps try and do that, you know, everything in one. And this is where, for us, it's so much about the partnerships. Like if we work with support organisations who are doing all the things that they're good at, employment, housing assistance, education, then we are complementing their services and hopefully being able to reach them at the right time. Emily, you asked me why this all started. So so my parents were refugees. My parents came to Australia in 1979. And so they were United Nations accepted Vietnamese boat refugees. And so for them, I think, like, not that, you know, again, like, not that that was a deliberate thing that made me think that this is what I was going to do. I think that, you know, the stories that we had growing up and seeing kind of how they navigated healthcare. So I'm the oldest of 3 girls, and I was always the one that, because English kind of became, you know, my predominant language, I would sit in their doctor's appointments and be translating for them using a Vietnamese English dictionary. And my first language was Chinese. So they spoke to me in Chinese, spoke to each other in Vietnamese, and our language was English. So, so if you think about the language, like, barriers and things, like, within our own household, and that still exists now, like, we still speak to each other in broken English, Chinese, Vietnamese, like a cross mix of stuff. But I could see for them that, you know, as I was growing up, that if they didn't have that understanding, and I was explaining to them, you know, as a 6-year-old child at some, you know, at one stage, then knowledge was kind of, you know, everything. And then sort of fast forward to intern year, I was working for a metropolitan hospital, which was full of people like my parents, non-English speaking, poor health literacy. And I think the reason why this is still going, to your question, is because I get really frustrated and angry with the fact that we don't have the same outcomes for people from refugee background. We know that, you know, they are less likely to engage in, you know, preventative health do the acute care stuff properly, medication adherence, like it's all of those things. And it's because of lower health literacy. So really what we're trying to do is level the playing field. We want them to have the same understanding as the everyday Australian. Having said that, the everyday Australian also could improve their health literacy. But it's really trying to make sure that they get what they're like, have the same entitlements as everyone else.
Yeah. And the point of Medicare and the point of our healthcare system is
universal
healthcare.
Correct.
And it's not universal if it's limited by access.
Yes.
And in that sense, because that can just go forever.
Yeah.
You can just take that to infinity.
Correct.
And then you get privatized healthcare at the end.
Exactly.
I think it's also really powerful what you said, that you're teaching communities, because communities are what people who are sick fall on.
Yes, correct. They rely on each other, exactly. And so, ideally they would be sort of teaching each other, and we would not, we would not exist. But at the moment it's, there's still that demand, there's still a lot of misconceptions, a lot of stigma, particularly around mental health. So I think there's still that narrative there, and we need to kind of turn that around.
Yeah.
As medical students and junior doctors, what are some practical things that we can be doing when we're interacting or communicating with people from these backgrounds?
Yeah, it's a really good question. I was reflecting on this last night, actually. I think there are some really good resources that I think everyone should know about. One of the resources that I direct a lot of my colleagues to is the SBS Cultural Atlas. Not sure if you guys have seen that. So you can look up many of the ethnicities and backgrounds of people who are in Australia. And what it has, which is fantastic, is not only a glossary of terms of some of the things that people might refer to within those cultures, but also a little bit around family structure, etiquette, customs and beliefs as well. And I just find that when you are entering into a community, like even little things like, do you nod, do you shake hands, do you not touch people? Just having that kind of baseline knowledge just puts you at a different level of, understanding and respect for that culture. So I think that's a fantastic resource. The other sort of tips around, I guess, working with people from refugee background are, obviously one, never to assume, and two, to be, I guess, inquisitive and sensitive, because just like, when we're talking to people who, in Paediatric ID, we talk about the anti-vaxxers and the vaccine hesitant individuals, I think you need to understand what their level of understanding or what baseline knowledge they're coming from. Because as I said, like most people are, trying to do the right thing and trying to do the best with what they know. And so if someone comes to you and they are not taking their medications correctly, or they're not going to their antenatal appointments, like what is the actual reason for that? And so, when we come to some of these cultures, one of the big stories that I talk about is working in a very busy tertiary hospital with an antenatal service and having a failed to attend stamp. And so that stamp, I think, has a lot of negative assumptions behind it. They failed to attend, they don't care about their unborn baby, they don't care about their pregnancy, they don't care about their health. But actually, if you were to ask one of these individuals, and we do in community, a lot of them will say, well, back in my home country, we never went to a hospital. Like, we delivered at home. We didn't need checkups as long as, my tummy was growing and
it's still there.
It's still there, exactly. Then I would deliver at home. I wouldn't need a doctor involved. I wouldn't need a sugar test or a blood test. Like, why do I need to come to these appointments when I've got 4 kids and I've got other commitments and I'm trying to juggle everything else in my life? So I think, being really sensitive is quite important. Obviously not using jargon, because we do use so much jargon, and I think we just can't help it sometimes. So I think, really kind of checking in with what you were saying and how you were describing it. And the other thing that I would encourage people to do is use check back technique. Have you guys heard of that before?
No.
So check back is this great technique where if you teach someone some knowledge, so say you tell someone to take a tablet 3 times a day after food because it might irritate their stomach, instead of kind of assuming the person who is nodding, sitting next to you nodding and agreeing with you understands, you ask them to explain it back to you. So I've just told you about your tablet. Can you tell me what you've just learned? And one, it reinforces that knowledge, but also it gives them some agency as well themselves to be able to say, actually, I do understand what the doctor just told me, and yeah, I get it, and that goes a long way in terms of medication adherence, but also it goes a long way in terms of their own, sense of self. And I think that's really important.
Yeah, 100%. I also think that, I think most medicine should come from the assumption that the patient wants what's best for them.
Correct.
And
absolutely
go back from there. And everything that feels like it's like, oh, they're going against the healthcare system is just a reaction based on what they know.
Yeah, I agree. I completely agree.
And if all they know is like, oh, I've heard that XYZ is happening. And also from online, it's so hard to battle the information that's online. It's so because of that, it's like an uphill battle at all times to have like the bland, boring healthcare information out there. And I was thinking about this actually. I was talking to a friend basically about like the impact of social media on this. He was not he's not within medicine.
Right.
He's one of the videographers with me. So basically he was like, oh, why is it that like I listen to all of these things online, but like it's completely different? Like you don't have any kind of answers. From medicine. Why is that the case? And I think from medicine perspective, it makes perfect sense. From what we can say is there's a 35% chance that if you take this, you'll get better. There's a 50% chance that nothing happens, and there's like a 20% chance that something bad happens, right? But like if there's something bad happens, we can know what to do. But online, it's the 15% that say, oh, this is the problem, and I have this problem from this drug, and everybody that listens to that, it feels like it could be them.
Yeah, oh, you're going to get this side effect from this vaccine, and it's super, super, super duper rare, but look, like if you did this, this is what's going to happen. Exactly. Yeah, I think what you, maybe I'm assuming, Sean, but I feel like with social media, obviously there is so much amplification and reach. I do think that in some ways social media is a good thing because obviously people at least are seeking out information. I think the danger is in the algorithms because obviously you enter this echo chamber and say you go down one sort of route in terms of, whether it's anti-vaxxers or miracle like detox or vitamins or, one of those things, then suddenly you get fed all of that information and it just keeps coming at you. And so it becomes hard not to believe it or not to feel like this is all there is. The other thing I'd say to that is that I feel like a lot of doctors and healthcare professionals, like we do ourselves a disservice because we're not good communicators and we're not good at getting in front of the public. And it's even harder in this kind of refugee population because they don't go through mainstream media. They're learning off WeChat and other forums and relying on community. And so whatever is kind of circulating amongst those communities becomes gospel.
Yeah, they have a completely separate. Yeah, I was gonna say.
Yeah,
it's completely separate.
Correct.
Even within like our university.
Yeah, that's true. Actually,
we can.
Like, international students will often use very different forms of social media.
Exactly.
So often you'll see, I'll walk past, like in the bathrooms, there'll be a sticker saying free STD check, for all STDs. But then it's some link to a WeChat thing. And it's
wow.
Yeah, we go, but across the university, there's a centralized GP service that works really hard to reach all students. But it's obvious that
we're not reaching
everybody, and that those forms of communication are still being relied upon, which may not be accurate.
That's right, exactly. And if you think about kind of the most vulnerable populations, they often aren't being targeted in terms of kind of mainstream media. And like we saw it during COVID, essentially we saw that a lot of the mainstream media was around, when we had lockdowns and what our restrictions were in Victoria, for example, but people weren't hearing it because they weren't watching the news because they don't get their, like news from the traditional, TV news. And so a lot of people were learning things about COVID on their traditional platforms or hearing things from back in their home country. So there was this huge divide and huge disconnect. And so I go back to my point that I think we need to learn better at how to communicate to people who really need that information.
And as someone who works in that public health promotion sphere, Why do you think it's important that doctors and other healthcare professionals are actually involved in combating misinformation?
Yeah, well, I think it's that stuff around credible voices because, gosh, like Kim Kardashian, who has, however million followers, is telling people to get those full body MRI scans, and yet none of us out there in the medical world are saying, no, please stop. Like, just, it's not, So influencers are giving medical advice that they should not be. And that's dangerous.
And we can't respond in time.
I know, well, we can't, exactly, because one, we don't have the follower base. But two, they have impact, even though they are not medically trained. And it's just, it's really quite frightening sometimes, the deep fakes that exist out there as well. Like, just, I don't know.
Yeah. I
think we have a lot to do in this space.
And have you found any particular challenges working in that space with traditional media rather than social media?
Yeah, I think, the challenges for me are more around the fact that we're not reaching everyone, and often, like, for example, with ABC News Breakfast, we are reaching a very educated audience, which is a good thing, but it means that you're not really kind of debunking those myths. You're kind of just perhaps reinforcing or, making people more aware of some of the issues. The other challenge for me, and this is probably more of a personal one, is that, when you put yourself out there in the public eye, you are prone to criticism, or it makes you vulnerable to that. And not that I've had negative feedback per se, but it always makes you feel a little bit, nervous as you walk out of the studio.
When you stand up, you cast a shadow inevitably.
Yeah. Something like that. Exactly.
So, that's a very big part of the public spotlight.
Yeah.
It's so interesting thinking even just about traditional forms of media that you're still reaching a target audience. And the people that you're talking to are likely, as you said, people who've got already a high-ish level of health literacy,
people, I reckon,
or they're willing to be challenged in their perspectives.
That's exactly right.
How do you reach the people who aren't willing to be challenged?
That's exactly right. And it's funny because people have the perhaps misconception in some ways that if you want to reach multicultural audiences, just get on SBS. But actually, not, like, a lot of communities don't watch SBS.
Yeah.
So, it's very stereotyped. And, we think about our traditional channels, 7, 9, 10 kind of being the broad kind of masses, ABC being, that maybe more educated audience, SBS being more the cultural audience. And it just doesn't work like that.
Yeah, I would say, I think there was a poll very, very recently that way more people watch Netflix than TV.
Oh, for sure.
Like orders of
sure. And that is self-curated content. Yeah. It's not like the news just pops up and goes, newsflash.
Yeah.
Learn about this, health issue.
Yeah. So you have to go to find it.
Exactly. Yeah. So, yeah.
And there's also, like, the mainstream media, there's a little bit less of, like, not as many people kind of watch it as a community anymore.
Yeah.
There's people that watch it, like, just while, like, going on the train or something like that. Everyone's got their own device, so it's very siloed.
Very curated content, algorithm driven. Exactly. And yeah, you're right. Like, a lot of people don't follow the news anymore.
Yeah.
And that really sad because I think it's good to be aware of kind of global issues and understand what's going on really.
As medical students and future doctors who are entering this space where there is just so much unknown and so much to do in this sphere of health promotion literacy, what do you think are some tips for thinking about how we go forward with all of that?
Yeah, it's a really tricky question. I don't know. It's really, I guess if you're doing any sort of media engagement, I think you need to know what your strengths are. And you need to be yourself, really, because there's no point trying to be someone that you're not. Like, people can pick authentic, inauthentic. And as much as possible, you kind of stick to your lane. So as much as possible, I try and talk about pediatric issues. I talk about infectious diseases where I can. Every so often I get thrown a bit of a curveball. But, if you talk about things that make sense to you and that you understand inside out, it is definitely easier to be able to communicate those things. I, during my training time, also did a Masters of Public Health. So,
just so many.
Again, because, I had some spare time.
Yes.
But
that we have lots of in medical
well,
school.
that's right, exactly. So I think, kind of going back to those health promotion principles, because we do a lot of health promotion in the MPH. It's around, I guess, aligning yourself with organisations and people who are already working in the space, and being able to elevate, their stories and their research and the stuff that they're doing, because, like I said, you can't be an expert in everything, and you need the right people to talk to the right issues. So I don't know whether that's helpful at all, but
It's helpful.
That's kind of
100%. And also, I think it's very valuable for people that are listening to kind of know that you don't have to start now, almost, if that makes sense. I think a lot of people in medical school are like, and then this needs to be information needs to be given out. Information needs to be given out. It's also valuable when you said to talk about what you know.
Yeah,
and
not everything.
And the start of that is
Yes.
knowing more.
Yeah, but also recognizing what you don't know. I think that's really important as well. And in this kind of AI age, everyone feels like they should know everything or or don't know anything. And so it's that really kind of fine balance, really, of where how much information can you deliver at the right time so that it is effective, in terms of what are your key messages. I think that's a really important thing to think about.
This is a very quick curveball, and this could be a whole podcast.
Okay, go for it.
But I have noticed that just within the past month or so,
Yes.
the amount of people that have said to me, just ask ChatGPT this. It used to never happen, and then it slowly started happening. I've heard it once or twice at the start of the year, and then now it's weekly.
Yeah.
I hear someone say just ChatGPT it,
Yeah.
or ask ChatGPT this thing, and luckily for me right now, it has not been medical stuff.
Yeah.
I am not shocked at all if that's what's happening with medicine.
Oh, for
People
sure.
uploading their entire biometric data onto ChatGPT. So these are my blood test results. What do I do?
That's concerning.
That's a completely a whole new podcast.
Yeah, of course.
But it is I have noticed that more people are comfortably asking ChatGPT for things. And it's only going to get better, and it's only going to get more. But yeah, something I've noticed. I'm going to put flag in the sand right now.
Yeah,
guys,
definitely.
it's happening.
Yeah, it's definitely happening. And yeah, I mean, we the adoption of ChatGPT, I think they said 29 days to reach 100 million users, as compared to the telephone, which was, I think it was 75 years or something.
Yeah.
So comparatively, the speed of adoption, and I mean, it basically is telling us we all need to get on this bandwagon.
I think also not just the speed of adoption, it's the speed at which people are becoming comfortable with it.
Yes.
Because it is exactly like texting a friend. It is exactly like just texting, asking Google.
Yeah.
You're already comfortable with the interface, and it just provides you the answer like that.
Yeah.
Yeah, confidently.
Anyway,
we need to get you back on. But yeah, thank you so much.
Thank you. Thanks for having me.
Coming on. It's been a pleasure chatting with you today.
That's been fun.
So many interesting chats about pediatrics, infectious diseases, refugee health, and finally learning on health promotion. But thank you so much for coming on.
Thank you. Thanks for having me.
Yeah. Good job.